All right, hello everybody. I'm Brian, and this is AAMI News and Conversation. We're here at day 2 of AAMI Exchange in Phoenix, Arizona, 2024, and I'm here with Meghan McNamara. We're going to be talking about the best research article of 2023. You won our Publications Award this year, so congratulations to you and your team. You're the co-author for Clinician Perspectives on Specifications for Metrics to Inform Pediatric Alarm Management, which, like all research papers, it's quite the mouthful. But what is it all about? What does that mean, pediatric alarm management?
Yeah, that's a great question. And thank you, Brian, for having me. And thank you to Amy for the support of our grant and our paper and our research. On behalf of the team, we're just super excited to have won this award. It was really fantastic. So
Great, that's glad to hear.
Yeah. So our research was really focused on trying to understand how clinicians may interact with some collated alarm data. So we held a number of focus groups with nurses and physicians where we asked them a variety of questions framed around the 5 rights of clinical decision support to understand how are they interacting with alarm data in current state? And then we asked them to think about that same or different alarm data in a hypothetical future state. And again, framed it around the 5 rights of clinical decision support, and how can we think about giving them a little bit more context to the alarms that they're managing on a daily basis. So this is a known problem. I think any of the nurses on this call or are listening in here will understand, receiving alarms or hearing alarms at the bedside via their, mobile device or, at one of the remote monitors on the unit. Getting ready to throw your phone at the end of your shift because you've experienced so many alarms. And how do we empower those clinicians to have a more informed conversation with their hospital provider to potentially mitigate some of that alarm burden? So how do we give them some, and how do we understand it from them, right? Like that's what we really wanted to get at the heart of this paper was how do we understand from them, what are they looking for when it comes to understanding that big alarm data?
So for those not in the know, when we're talking about alarms here, it sounds like not every alarm is an actionable alarm, right? Are they all still important? Is it just to inform you at certain parts of the day? How can you have too many alarms and it not be a problem?
Well, I think that highlights one of the fundamental reasons that we're studying pediatric alarms here. And we, in pediatrics, we use monitoring in a variety of ways, but we have a ton of what we call nuisance or non-actionable alarms in our pulse oximetry for our patients. So for pediatric patients who, might be babies in our NICU or in our general pediatrics unit, they have a pulse ox on and they're in their bed kicking around, and we're getting tons of nuisance alarms that are not reading appropriately, not actual alarms.
Baby moves might have knocked their pulsometer off.
Oh,
their
yes,
arm.
exactly.
I see. Okay.
It can fall all the way off. It can just not be reading appropriately, and you get sort of a wonky waveform. You've got a lot of variety there. And as I like to say, I think kids, as they start to get better, they start to maybe have more alarms because they're standing up in that crib. They are ready to go home. So,
So on monitoring, it looks like there's a disaster happening.
Right.
But the kid's actually feeling better.
Yeah,
That's interesting.
Yes, exactly. And of course, that can also be, not true on the other side. You can have kids who, start to have high levels of alarms because they're actually having a change in clinical condition. And so it's really, trying to get at that context of the alarms and trying to understand the background around what the patient's actually experiencing.
This sounds like such a complex problem. And I come from a scientific background myself, and I'm having trouble imagining how you could set up a good experimental model or analysis. And how do you figure this out? Holy cow.
Well, we went to the people who are experiencing this, and we asked them those questions about, things like, how might you use, if you were to receive an alert that said you've received the highest number of alarms in the hospital today, how would you how would you interpret that information and what would you do with it? And so asking them those questions about, things like that, asking them to think about that hypothetical future state, allowed us to start to tease apart some of the potential interventions that, that were sort of, in our results. So we started to think about, how can we take that flag and then have an informed conversation with the hospital provider on what do we do here? This is a problem. We've identified it. We've gotten this flag or this alert, or again, these are all hypotheticals in current state, but in a potential future state, as different technologies come online, how can we start to support clinicians in that conversation and then make action to reduce that alarm burden and make the alarms more salient. And that's really our ultimate goal.
That's fantastic. So I guess tell me a little bit about these conclusions that you and your team reached. How are we going to be taking these next steps?
Yeah. So, I think one of the things that it really highlighted was, need for increased situational awareness around alarm burden and alarm fatigue, and making sure that we have a shared mental model between all of the clinicians on the healthcare team about the risks of alarm burden. We've heard it from the Joint Commission. We've heard it from ECRI. These are high risks. This is a high-risk problem that we have in the healthcare space. And so making sure we have that shared situational awareness. And
just as an aside, when we say alarm fatigue, it's a buzzword I hear quite often, but we're talking about, I hear so many alarms every day, it almost becomes a situation like the boy who cried wolf. I start to ignore them just because.
Yeah, and I think it's not even just because it's, every alarm is a distraction. It's an interruption from something that I might be doing as a nurse that's actually really critical care that I need to be providing. That could be preparing medications. It could be doing sterile procedures at the bedside,
Things that need focus.
Things that need focus, exactly. So I think, some of the things we've heard from our nurses is, it's not that I want to ignore that alarm, it's that I have to in this situation.
That's wild.
Yeah.
Okay, so we were talking about conclusions. I'm sorry, I derailed us there.
No, totally fine. So one of the things that we talked a lot about was, how do we, and sort of supporting our staff in getting that information to them and then supporting them in that conversation, and the need for real-time alarm data in that moment, and then supporting that shared mental model across the healthcare staff so that we could support that sort of conversation and then allow for some standardized interventions to reducing the alarm burden in that moment. Again, maybe that's understanding the context of that alarm, whether that's, this is actually a change in clinical condition, or in either direction, right? So positive, it's that baby who's getting ready to go home, or, maybe we need to think about other, pulmonary interventions and things like that. So really helping provide that framework for staff to have that informed conversation, with data that's meaningful, that actually has information that folks can act upon. So whether that's teasing out, the right information piece of the 5 rights of clinical decision support. So, how many alarms are actionable, how many alarms are non-actionable, how many are nuisance, and that's information we're still really struggling to get from the system right now. But I think those are steps that further researchers could think about taking in the future.
And it sounds like this is information that should then be informing a department. Say, oh, hey, we have to make some changes in XYZ areas because we've observed this. Is that right?
Yeah, absolutely. I mean, I think at CHOP we have a really strong partnership between our operations and research partners. We, my role is actually operational, and I've worked really closely with Hallie to understand the research coming out of her grants, across her multiple research grants. And so I think we've been working towards trying to translate our research back to the bedside, and there's some exciting opportunities coming up with new technologies, and I think we're really excited to think about how do we take this research that's informed some of the workflow piece and make sure that we can translate it into our workflows as those technologies come on board.
Right, funnel the right data through patient monitoring technologies.
Right, exactly.
That's fantastic.
Yeah.
So what's next for the team in general?
That's a great question. We have recently started our physiologic monitoring committee and really formalizing that structure at CHOP. So we are excited to see, again, how we can bring that translation of research into operations. And, that's really an expanding committee full of engaged clinicians who are really excited about this work, and Hallie's been integral in that. So I think we really have a lot of opportunity to expand that group and really try to tackle this from a multi-dimensional way.
Yeah, and you mentioned Hallie. We should point out that's Hallie Ruppel. She is the lead author for this paper.
Yes.
But congratulations to all of you who are on this paper. It was a big team. Everybody from CHOP, right? No other outside institutions? Do you have any collaborations going on?
No, we received the AAMI funding for this paper, and it was really integral in our ability to partner with our human factors engineers. They're internal at CHOP, but they are, amazing colleagues, and they really,
Important perspective.
Yes,
Sure.
exactly. They really pushed us to think about this work and the data that we got from the focus groups in, framing it against Norman Nilsson's usability heuristics. So we were able to think about that in a unique way. And so they just bring such a great perspective, and the funding really allowed us to work with them closely. So we love our partnership with our human factors team.
Fantastic. Well, shout out to the Human Factors team. And
Absolutely.
again, congratulations on this award. We're looking forward to hearing more research come out of this, but enjoy the rest of Exchange in the meantime.
Yeah, thank you guys so much for having us. Really appreciate it. Thank you.
All right.